Hi, everyone. My name is Megan O'Rourke, and I'm the Associate Director of Regional Programs for the Office of Alumni Relations at USD. I am also a proud member of the class of 2015. We are happy to have you for today's event, Vaccine Hesitancy, Addressing the Concerns of Specific Populations, brought to you by the USD Hahn School of Nursing and Health Sciences and the Minneapolis Torero Club. 2020 and the beginning of 2021 has been an interesting year and some change, especially through our work with the University of San Diego. However, during this time, the Alumni Association is continuing our efforts to keep alumni engaged with and connected to the university, in addition to providing events that are of the best and greatest needs of our alumni, especially current needs. One of those needs is having a better understanding of the COVID-19 vaccine, what it is, why it matters, and how it is affecting specific populations. But before we begin, we would like to extend our thoughts and prayers to the Minneapolis health community who were affected by the shooting at the Alumni Health Clinic yesterday. As you can see, with what is going on in the world, especially with the emergence of the COVID-19 pandemic, now more than ever is the topic of vaccine hesitancy in the forefront of everyone's minds. Well, we have a great robust program for you today. So we're gonna go ahead and get started. At this time, I would like to introduce Christina Bergstad, class of 2008, Minneapolis St. Paul Torero Club president, to briefly talk about the Minneapolis Torero Club and to introduce Dr. Fry-Bowers.
Hi, everyone. Thanks, Megan. As Megan mentioned, I am a proud alumni of class of 2006 and 2008. And I am the president of the Twin Cities Torero Club here in Minnesota. And we are a small but growing group here in the Twin Cities. And since the pandemic began, we have held a variety of virtual events, including a Welcome to the Twin Cities event, where we got to know others in the area and got to know the Torero Club here better. And also a program that was a seminar for various financial relief options for business owners. And we are excited to partner with important and informative conversations with our campus partners at the Hahn School of Nursing and Health Sciences, especially today with Dr. Ferris, who works in Minneapolis and can speak directly to the Torero community here in Minnesota. At this time, I would like to introduce the moderator for tonight's event, Dr. Eileen Fry-Bowers. Dr. Fry-Bowers is an associate professor at the Hahn School of Nursing and Health Sciences, associate provost for research administration, and chair of the USD Institutional Review Board. Dr. Fry-Bowers, the floor is yours.
Thank you so much, Christina. Let me go ahead and share my screen. I hope that everybody can see that, and we will go ahead and get started with tonight's event. So thank you all for joining us for the second night of our two-night event on vaccine hesitancy. Tonight, we attempt to address the concerns of specific populations with regard to the COVID-19 pandemic. Before we begin, I would just like to briefly recap our discussion from last night's webinar. As you may recall, we reviewed the human impact of the COVID-19 pandemic and acknowledged the significant disparities and inequities that have amplified the toll on many communities. We discussed the timeline and the process of the development of the currently available vaccines, along with their mechanism of action. And while the vaccines are currently being distributed, we noted that existing and expanded vaccine monitoring systems at the CDC and the FDA continue to review the data to ensure that the vaccines are safe and effective. We also discussed how many factors at the individual, family, community, organizational, and policy level influence an individual's knowledge of and acceptance of and confidence in vaccines. When we discuss vaccines, whether we are talking with friends, family members, colleagues, or patients, we need to meet people where they are at. We should ask specific questions in a non-judgmental manner that allow us to address their unique concerns and provide clarifying information. And we should direct individuals with concerns to authentic and responsible resources. And so now let's continue this important conversation on how we can move from vaccine hesitancy to vaccine confidence. Joining me tonight are my colleagues, Dr. Pedro Colio and Dr. Dorothy Forde. Dr. Colio is an adjunct clinical associate professor at the USD Hahn School of Nursing. His area of clinical practice includes emergency, cardiology, and family practice, and he has spent over 10 years working in underserved communities. Dr. Colio will discuss how the rampant spread of COVID-19 affected one of the most vulnerable communities in Southern California and why vaccine hesitancy persists among the Latino population, specifically middle-aged adults. Dr. Forde graduated from the USD School of Nursing in 2018. Her doctoral dissertation focused on the effects of kangaroo mother care, and she recently completed a postdoctoral fellowship in symptom science at the University of California, San Francisco. Dr. Forde has extensive experience in working to improve the health outcomes of infants, especially in Black and Brown communities. Dr. Forde will be addressing the COVID vaccine as it relates to pregnancy and childbearing families. Following Dr. Forde's presentation, we will bring all four of our panelists back together to answer questions. And now I'd like to turn the discussion over to Dr. Colio.
Hello, everyone. Thank you, Dr. Fry-Bowers, for that great introduction you gave of me. Like you said, I'm adjunct faculty at the University of San Diego. I'm also a nurse practitioner. I have a doctorate degree as a Doctor of Nursing practice, and I'm currently a PhD student in nursing. Let me share with you my presentation, and I'm going to try to be concise so we can have a lot of questions towards the end of their presentation. Okay, so here's my presentation. I hope you all can see it. So vaccine hesitancy, the title, COVID-19 vaccine hesitancy, underserved communities and Hispanics. So is vaccine hesitancy really a problem among Hispanic community? You know, we have JLo here looking and thinking, is it really a problem among the Hispanic community? According to recent polls, so the most recent one is going to be the Kaiser Family Foundation, says that among whites, there's 26% hesitancy. Hispanics also have 26% hesitancy. So it's about the same. So it makes you wonder, there should be no statistical significance among these two groups, correct? So the answer, unfortunately, even though they have the same percentage, according to this recent poll, the answer is no, same percentage, different outcome. So what may that be? Why is there a different outcome among Hispanics versus whites? And the reason why is because of health disparities, social determinants of health, chronic comorbidities, diabetes, hypertension, chronic cardiovascular disease is very prevalent among the Hispanic population. Also poverty and living on overcrowded living conditions. So that is very prevalent where I live. I live in Imperial County, and it's one of the most underserved communities. And we were affected so much that we even came out in national news, New York Times, we were all over the news. This place felt like we were in Vietnam War because I live very close to the hospital, and I felt that there was helicopters flying day and night, transferring patients of critical care to other facilities. So according to the latest polls, which groups are most likely to be COVID-19 vaccine hesitant? This is the Kaiser Family Foundation. So this was published in January of this year. And if you can see here, we have Republicans at 42%, down at the bottom, 12% for Democrats. So meaning that Republicans were more hesitant about getting the vaccine. So why does this matter when it comes to Hispanics? So Hispanics, Latinos, they have very strong Christian and Catholic beliefs that go hand in hand with the Republicans' beliefs. They don't believe in abortion for the most part. So they tend to have the same beliefs, and they may refuse the vaccine just as much as Republicans. Now, if we look at the number down here, we have white adults at 26% and Hispanics at 26%, and that was the number that I gave you before. But we have to keep in mind that wearing a mask and getting the vaccine has been politicized, and that unfortunately has affected the delivery of vaccine and vaccine hesitancy. Now, comparing vaccine hesitancy across the lifespan. When it comes to child immunization, not typically a large issue among the Hispanic community. And this is why, because Hispanics tend to have strong respect for physicians, for medical providers, and typically whatever they say, the Hispanic community will do. But when it comes to the CDC, when it comes to influenza A, B vaccine, it's a complete different story. According to the CDC 2020, white Americans have 53% coverage of the yearly flu vaccine, African Americans at 42%, and Hispanics at 38%. So why may that be? Why are Hispanics hesitant about the flu vaccine? And it's usually due to preconceived notions of what the vaccine brings. Sometimes they think it's gonna make me ill, et cetera, et cetera. But one interesting thing that I noticed on the web and on the recent articles is that in 2016, when the HPV vaccine came out, it was a de novo vaccine, a new vaccine to prevent cervical cancer among women. Hesitancy was lower among those of Hispanic ethnicity than other groups. So with influenza A and B, the hesitancy transcended into the COVID-19 vaccine. However, when the de novo new vaccines for HPV, Hispanic population were very prone to give it to their children. And it makes you wonder, why is it that in 2006, a de novo vaccine was widely accepted by the Hispanic population, and not now, and now into 2021, they're not accepting the COVID-19 vaccine? And there's speculation that it may be related to social media and the disinformation that is provided by the social media. Hispanic population is highly affected by this. So vaccine availability and underserved communities. So let's put the example of Imperial County. Population 181,215 inhabitants as of January 2021. First shipment to Imperial County of vaccines, about 900 of them went to healthcare workers. 600 of them went to tier 1 group. They'll be older than 65 with comorbidities. Imperial County has one of the highest mortality rates in the state and the nation. And to me, when I looked at these vaccines, it seemed this is very little. Most vaccines went to healthcare workers. Of course, we've received more shipments of vaccines, but not enough for the mortality rate. In the Imperial County, we received assistance by the military, by DMAT, which is Disaster Medical Assistance Teams, and the US Public Health Services. So we have tents outside of the hospital because, like I said before, it looks like a Vietnam War out here. So I decided to call the Imperial County the hot zone. If you look at this map over here, Imperial County is way at the bottom in the dark blue. So we're in the dark blue because we have the highest hospitalization rate and mortality rate. According to California census, we have 1.2% death rate overall in California. San Diego is about 1.1% mortality rate of patients with COVID-19. Los Angeles, 1.5%. And look at Imperial County, 2.9%. That is double of California, more than double. If we look at Imperial County hospitalizations and mortality rate, the overall is 22%. So that means that of every 100 patients that get admitted to our local hospitals, 22 of them will die no matter what the age is. When I looked at the numbers for adults older than 55 and older, 58% of them died, meaning that out of 100 patients that are older than 55, 58% of them died. That number is huge. And it makes you wonder, why is the Hispanic population being affected the most? If you look at most recent polls, you'll see that in California, most hospital beds are being occupied by Hispanic Americans. So despite the mortality rate, vaccine hesitancy is on the rise. So we have Instagram, Facebook, WhatsApp, and YouTube. And the speculation is that they may have something to do with this, but not particularly the company, but people who have access to provide you with misinformation and most of all, disinformation. So which Hispanics are at high risk of refusing the vaccine? Elderly with poor functional status. Why? Because of family beliefs. Hispanic cultures, typically, they have high respect for their elders, and typically the head of household will make decisions for the rest of the family. If dad says, you know what, I'm not getting the vaccine because I don't trust it. I saw something on WhatsApp, on YouTube that I don't like, the rest of the family will say no. And unfortunately, that elderly adult that lives in the home with chronic comorbidities will not receive the vaccine due to the fear from the rest of the family. Now, there's also speculation that having no college degree affects you in the decision whether you should get vaccinated. So I don't fully agree with that, because not having a college degree, you can still make a rational decision. And we all have some hesitancy when there's something new out there. But what really affects in the Hispanic culture is that having no college degree, you have difficulty deciding what's a good source of information from a bad source of information. And instead of going to PubMed, a library, to the government, CDC, public health department, you may get your information from a YouTube video from a non-credible source. And unfortunately, Hispanic population is being highly, highly influenced by WhatsApp, Facebook, and YouTube. And I have clearly seen this in the clinics. I work in family practice, cardiology, and emergency medicine. And I ask all patients, why are you planning on getting the COVID vaccine? And if they say no, I ask why. And I always get back to conspiracy theories. So remember I said college education has nothing to do with it. So what about those with college education who are not receiving the vaccine because of hesitancy? Hispanic community, they have strong beliefs, Catholic and ethical beliefs. They also have strong respect and trust for the elderly and the family who's going to make decisions from them. And I don't fully agree with this, but there is some truth to this, and this is a stereotype that Hispanic populations are very superstitious. I grew up in a strong, Hispanic Mexican family, and my grandma would tell us a lot of stories. And unfortunately, that can sometimes lead to being victims of conspiracy. And many immigrants that come from other countries have mistrust in the government, because some of them come from socialist countries and they think that the government is out to get them. So if the government is telling you, get this vaccine, everybody needs to get this vaccine, they may not trust the government and decide, I'm not going to get this vaccine at all. So I have a little quote here. I'm not superstitious, but I am a little stitious. Guilty of that too, because when I got my vaccine, I was even hesitant as I was waiting in line. I was having second thoughts because it's a new de novo vaccine. And I was worried, but ultimately I got the vaccine and I'm proud of it. So Hispanic vaccine hesitancy. So we have multiple reasons why there's hesitancy. One of the number ones is fear of the unknown. And that's not just Hispanics, that's everyone. But when I'm looking at Hispanic populations, preconceived notions of the influenza vaccine, they're all related to the flu shot. And things that I'm hearing out in the communities, why are you not getting COVID-19 vaccine? I never get the flu shot, I won't get COVID-19. Flu shot gave me the flu, therefore I will not get COVID-19 vaccine. I had a bad experience with COVID, with the flu shot. I only got the flu shot once, and that time I got the flu. And the other one is they get the flu shot and they get a common cold and they think, oh, I got the flu, so therefore I got the flu shot and I got a common cold, therefore the flu shot didn't work. There's a significant difference between influenza A and B and the common cold. And unfortunately, there's a lot of people out there that don't know the difference between the two. Flu shot does not cure, does not prevent the cold. So the effects on social media. So hesitancy among Hispanics, like I said before, is due to social media. These are some of the things that I've heard on by my patients. COVID-19 is the mark of the beast. 666, it's in the Bible. They're gonna mark us all, and if we don't get it, we're not gonna be able to buy anything. So I'm scared. Bill Gates and George Soros microchip. And I do not want that as it is. The government, I don't trust them. With that microchip, they're gonna try to deport me. And then I asked them, who's George Soros? And they don't even know George Soros, but they knew Bill Gates. a lot of them. Dr. Fauci's the Antichrist, fear of cancer. That one's a legit one, you know, the new de novo vaccine. But we have to get it. New World Order, population control, sterility. Funny thing is the sterility one, I heard it from a 70-year-old male who told me, oh, I'm not going to get the vaccine because, you know, there's rumors about sterility. I'm like, oh, you're really planning on having children? And of course, the one we all heard about is DNA alteration. If you don't understand basic biology or the difference between RNA and DNA, of course, you're going to be fearful. And with all this disinformation in the media, of course, you're going to fear it. So how do we fix this issue? By having events like this one, like one we're having today, with community awareness. We need to have public figures speaking out in the community, on TV, on social networks, community officials, religious representatives would be great for the Hispanic population, priests and pastors, because they're strong, they have strong religious beliefs. Popular, as ridiculous as this may sound, we may need popular YouTube influencers putting facts on TV. Maybe you can have Jojo Siwa out there, you know, giving some information on the vaccine. How do we reach them? We saturate social media with facts. We use Facebook, WhatsApp, Instagram, and YouTube. And the one that's my favorite that I'm trying to implement at the cardiology clinic where I work is using primary care providers with specific telehealth and phone visits to address COVID-19 vaccines. So just call every single patient. We can technically bill for this. And you know, there's a profit and we're doing a great thing for the community. Call them, hey, are you considering the COVID-19 vaccine? And then provide them some 10 minutes of information and move on to next patients. However, even when we solve the hesitancy issue, there's not enough vaccines for the underserved community. Regardless, we must be prepared for the future because I do not personally believe this is the last time we have a pandemic. We have a exponential growth in this world. And, you know, unfortunately, we may have another pandemic with a different virus. And I don't want to scare anybody out there, but by preparing and educating the public, if this happens again, we'll be better prepared with masks, gloves, washing hands, and getting the next vaccine. So COVID-19 vaccine supply and demand, there's a high demand for COVID-19 vaccines. Vaccines are distributed based on population census. So if San Diego has 3 million people, they're gonna send X amount. If Imperial County has 181,000, they're gonna send a certain amount of vaccines. And unfortunately, I do not agree with this. Vaccines should have been distributed based on county hospitalizations and mortality rate. If we allocated resources in an emergency department the way that COVID vaccines were allocated, a lot of people would die. So let me put things into perspective. If we have 10 patients, and of those 10 patients, 2 of them have significant trauma or a heart attack, and they come to the emergency room, we're gonna allocate all those resources and nurses and treatment to those 2 patients to make them survive, instead of spreading all the resources evenly among those 10 patients, because some of them may just have a sprained ankle, an abrasion, a laceration, something simple. And if unfortunately we continue to do this and spreading the vaccine evenly and not distributing it to locations where the mortality rate is really high, the mortality rate is gonna keep going down maybe, but very slowly. If we target high risk communities, the mortality rate drastic drop. And these are my references, and thank you. And I hope I did not go over my 15 minutes. I'm sorry, Dr. Fry-Bowers, if I did. And now I want to take off with Dr. Forde, if you would like to present. Thank you.
Dr. Colio, thank you very much. And it's a pleasure to be here with you. And I am just gonna get right in and share my screen with you so we can get started. Can everybody see that? Can you see my screen?
No, we can't.
Oh. Okay, let's go and do it again. Did you stop share, Dr. Colio?
Yes, I did.
Okay. So we're there. I'm going to share our screen. Now, can you see it?
We can.
You can, good. All right, let's get started. So the color of COVID, and we're thinking about the vaccines and vaccine hesitancy. So vaccine hesitancy among African Americans is not without reason, because we have the legacy of the Tuskegee study that went on for 40 years. In 1932, Black men who had syphilis were promised that they would get a cure. And within 15 years after they started that study, penicillin was found as a treatment for syphilis. But the study went on for 40 years, and these men were never given a treatment. So we do know that there are some reasons for the hesitancy of vaccines. One student, I asked him, he's a nursing student here where I am, and I said, "Are you going to get your vaccine?" And he says, "No, I don't trust them," he says. And so we know that COVID then has killed nearly 500,000 people in the US. So when we look at this graph right here, we're looking at risk, not rates, but risk, more likely. So if you look at all the different races there, you will see that if you are Native American, you have a 3.3 risk. If you look over to the right, and Latino, you have a 2.7 risk. And Blacks, you have a 2.7 risk too. And of course, Pacific Islanders have a 2.3 risk, and Asian and white have 1. So, but then when you look at the numbers that are over to the left by the races, you'll see the amount of people that died. So 2,800 died with Native Americans, 51,000 of Latino have died from COVID, 50,000 Blacks, and 435 Pacific Islanders, Asians, 9,400, and 151,354 white people have died. But the way we talk about it, you'd never think that. But because white is the larger population, that but you're hearing about the Blacks, the Latinos, the Native Americans. You're hearing about it because they are more likely to get COVID and to die. So we have vaccines now. I don't want to go over what Dr. Fry-Bowers said, but we have 2 vaccines, the Pfizer and the Moderna vaccine, and their mRNA vaccines. So we have those, and they're available to everybody. We like to really tell populations of color that this is the role, here's the role of a Black scientist, Dr. Corbett, who is a leader of the Vaccine Center Research for Dr. Fauci's NIH agency. And she has been a key scientist behind the development of the Moderna vaccine. Just letting you know that minorities also have played a role in the contribution of the science that has developed the vaccine. So we know then that the vaccine is available, it's free. And now we don't know though what to do with our pregnant women. They were not a part of the trials. The Pfizer people had 44,000 people in the trials, and Moderna had about 30,000. So the point is, they did not include pregnant women, but the American ACOG and all the pregnancy maternal people have decided to go and look at some regulations that would help them. So pregnant women, we know that they may be at greater risk for COVID-19 symptoms and worse pregnancy outcomes. The studies to date have reported higher risk of pregnancy complications, mostly preterm birth, and some preeclampsia, as well as higher rates of cesarean delivery. COVID, it's not passed transplacentally, no vertical transmission so far in the studies that we have looked at. And there seems to be an increased risk of preterm birth and maybe some risk of stillbirth. Suspicious infants, they do get, like suspicious infants that the mom is positive, they do get like a nasopharyngeal test and they get screened away, they get separated from their mom. So there's very little data for the protocols that are in place. Every woman that comes to the labor and delivery is screened with questions and then tested. And if she's symptomatic, she's isolated, and then the caretakers have to do the full gear of PPE, and it's applied to her too. Infected moms were still allowed to breastfeed now, but at first they were separated and they weren't allowed to. The FDA and CDC are encouraging pregnant women that they should also have access to the vaccine, and that the vaccination during pregnancy should not be differentiated by trimester. We should just have the ACOG and Royal College of Gynecology, they've all decided that the Maternal Fetal and Maternal Fetal Medicine Society are also recommending that women have access to the vaccine. So we are now seeing that those protocols that were kind of very strict were not very good. And so they've put out a new protocol for COVID-19 pandemic with mothers and making sure that the babies are breastfed, direct breastfeeding. So with newborns, we really went very strict on the guidelines. We separated newborns from their moms. We immediately bathed the babies. We avoided direct breastfeeding and put the babies to just have formula. And we isolated them if they had positive moms. And we treated the newborn as a person under investigation. And so it made it really difficult because moms and dads, if mom was positive for COVID, we would tell the dad, you have to choose who to visit. You can either visit mom, but you can't visit the baby. And the baby would also be isolated. So the dads would decide, well, we'll visit the baby, but we won't visit mom. So it caused very, very difficult problems for them. And we've now realized that some of these protocols that we had were not necessary. So we had some small samples of case studies from China, Wuhan, and some other regions. We had 86 newborns tested there and 42 in Northern Italy, and United Kingdom, we had 244, and New York City, we had 101. And these studies have provided some robust evidence. Of a total of 836 newborns that were studied, only 35 newborns tested positive by PCR, and no respiratory or other illness in the newborns to mothers who were positive. And so we see that the general indicators of newborn health, that the APRN scores were similar to the ones we have here in the United States. They were 7 and 5 minutes, and that approximately only 22% of newborns studied were born premature. So it's higher than the average national, US national average of 10%. And the PCR that they had, which is a polymerase chain reaction, the swabs that you put in your nose, they confirmed infected infants, but the infants only showed typical mild to moderate symptoms. They cough, or they had respiratory distress, fever, pneumonia, and that some infants were asymptomatic. But they found on a whole that infants that were born with moms that are positive, that there is no vertical transmission, and that they do pretty well. They get well in about 2 weeks. They have the symptoms, but in about a week or two, they can go home. So we know what we would like is for mothers, for pregnant women, to be in a clinical trial so that we can have good and robust evidence to give to everybody about the vaccines. And the last slide, I'm going to stop there, where these 3 ex-presidents, they took their vaccine, and pictures were taken. And so we want to encourage everybody that when you get a chance, when it's your turn to get the vaccine, please go ahead and get the vaccine. And with that, I am done. Could you hear me?
Thank you so much, Dr. Forde. And thank you, Dr. Colio, for those terrific presentations. I would like to go ahead and invite Dr. Colio to turn on his camera, as well as Dr. Ferris and and Ms. Ball to turn on your cameras, so that we can go ahead and answer have a Q&A session with our audience. And we did receive one question in the Q&A, real-time Q&A. And so I'm just going to go ahead and start with that. And I'm going to just sort of open it to the group to talk about the experience that you're encountering with regards to this. But how do you see access to insurance, or perhaps internet connection, or even just routine medical care affecting how individuals think about the vaccine? So I'm just going to open that up to all of you to answer. Don't chime in all at once.
I can answer something quickly about that. In my research, I was at a university clinic, pediatric clinic, and it was surprising to me as I was sitting in the waiting room, waiting for my subjects to process on the iPad I had for them. But it was interesting to hear them checking in with the desk staff. And one woman, I remember hearing her say, and this was in 2016 when I did my study, I heard one woman say, well, how much is it going to cost? Because she was there for a well child vaccination visit. And she said, oh no, you're here for well child vaccines. So we don't charge you anything. There's no copay. And I was surprised, because the Affordable Care Act, within the Affordable Care Act, it states in there that vaccines are no cost when they're CDC recommended vaccines. So I think part of, how does access to insurance is kind of a personal health literacy in that if you don't have access to insurance, the caveat to that was if you didn't have Affordable Care Act or any health insurance, was that there's for children, there's a Vaccines for Children, a federal program for underserved populations, as well as people that are not under underserved populations, but just don't have health insurance. You can go to your local public health departments a lot of times. So a little bit of health literacy, maybe vaccine hesitancy might be that I can't pay for the vaccines. I don't have any money to pay for them. And certainly this administration and the previous one said that the COVID vaccines are going to be free. So we just have to make sure that that message gets out.
Great response. I think also we need to think about just the way that vaccines, the appointment process, right? We're hearing a lot of challenges with the appointment process. And when we think about, for many communities, those appointment processes are conducted through the use of the internet. So if you don't have reliable access to the internet, or perhaps you're not comfortable using the internet, maybe with some of our elder population that aren't as familiar with technology or whatever, that can certainly be a challenge. Any other thoughts?
I don't think insurance affects your decision on getting the vaccine at all. I've seen patients with Medicaid, Medicare, and private insurance getting the vaccine. And the other thing with internet connection, it doesn't affect your decision with hesitancy if you're able to navigate through the network and know what's good and bad information. But what it does affect is, at least what I've seen here, Hispanic populations that live in poverty typically do not have cable TV, and they can't sit there all morning watching MSNBC with the updates. So they rely on WhatsApp and videos on YouTube to determine, like, you know what, I'm not getting the vaccine. I don't like all the stuff that I'm hearing about thrombocytopenia, about mutations, et cetera, et cetera. And another thing, another question here, any update on the vaccine on children? So supposedly by June, fortunately, children are a protected group. You can't just do research studies on children. You have to have, IRB approval, and they're a protected population. So you can't just throw in a vaccine out there and give it to children without proper studies. If the studies are well and done correctly, and the studies show proof that they're going to have immunity, then maybe by June.
So we do have actually clinical trials are occurring right now. Pfizer is actually actively enrolling. And we have to be careful about how we describe children. So right now the clinical trials are in age 12 and above. Okay. So presently the Pfizer vaccine was tested in 16 and above, and the Moderna vaccine was tested in 18 and above. So when we think about children, we have to think about adolescents. They are in that range. So there are some communities that are beginning to think about how they will roll the vaccine out to the 16 and older group if they're able to use the Pfizer, and the 18 and older group for perhaps some of our seniors in high school. Currently, Pfizer is enrolling, AstraZeneca is enrolling. All of them are enrolling at the age 12 and above. Yeah. There is some consideration about a 6 to 11-year-old clinical trials that are going to begin soon. So we just have to keep our eye on what the outcomes, as Dr. Colio said. But as you would imagine, enrollment is a little challenging with regards to, children and getting them involved in these vaccine trials. So let's see, what else do we have in our questions? So we've answered the question about the update for children. Let me throw this out to you all. And we've talked a little bit about this misinformation. So I would like to know, for those of you who are, talking with your patients, how are you addressing, are your patients bringing in information and asking you about it, or are you asking, are you going to take the vaccine, and they just say no? How does that conversation take place? And what are you doing to correct any misinformation?
I can go. We get phone calls every day. Can I get the vaccine? I have these comorbidities. Where can I get the vaccine? So it's on a daily basis. But sometimes when we see patients in the community at the end of the visit, I always ask, do you plan on getting the COVID vaccine? If they say no, I say, why? And typically that's when I get all the answers of the typical stuff that I hear and the conspiracy theories. And then I give him my spill. It's like a 5-minute spill. I'm telling them, you know, you can't rely on everything you see on the web. You have to go to the correct resources. And here is a fact sheet on the vaccines that we have available in Imperial County, which is Pfizer. And then we're doing this trial with AstraZeneca if you want to be part of that. I provide him with that. And then typically we'll do follow-up phone calls with these patients, and we're, you know, making a habit of asking if COVID-19, if they're COVID-19 vaccine, if they're planning on getting it. And many times they do change their mind, other times they do not. And that because it's cultural. If dad doesn't want the vaccine, rest of the family doesn't get the vaccine.
And here in the South, we're opening up vaccines in Walmart, in CVS, in places that will be open to anybody. So they wouldn't have to be afraid of a clinic or afraid of having to pay at a clinic. It'll be just everywhere where they go and will be available to them.
Ms. Ball, I would like to ask you a question. You know, Dr. Colio just brought up this idea that, you know, they'll get the information and say no. What about, you know, these opportunities to re-engage after somebody has already said no? You know, what should we do? Should we keep asking? Should we, you know, take no for the first answer and that's it? How should we address that?
Yes, so keep engaging, definitely. Continue asking questions that are a lot more open-ended. What is it that you're concerned about, and letting them talk about it, and where have you heard this information? Similar to like what Dr. Colio was just saying, you know, what sources are you using to make these choices? And, you know, asking them, is this a lot of what Dr. Colio was saying too, like, where are you getting this information? And is this always your source of information? Has there ever been another source of information that you've gotten things from that you felt was more reliable than the other? And really kind of very delicately, like, open-ended questions of like, is this, you know, maybe comparing and kind of leading the conversation to more. I think sometimes when we're really direct, it can be very much like, oh, well, they're just not going to listen to me right now. So being a little bit more open-ended with how you're asking the questions is really helpful. When and one thing that we do in motivational interviewing is what I talked about yesterday, is asking permission to give advice. Even though we're going to say, you know, I'm a nurse practitioner, and this is, you know, good sound medical advice from, you know, what we know about the evidence. But, you know, can I let you know what this evidence is versus let me tell you I'm right, you know? So that's really, I think,
Yeah.
Thank you so much. I'm just going to go ahead and bring us to a bit of a wrap up here, since we want to make sure that we can close tonight's talk. There are so many questions that I'm sure we've left unanswered. And as we mentioned before, we will be providing additional information. I just want to go ahead and share my screen one more time and sort of wrap up our conversation tonight, since we are at 5 to the hour. So in bringing our 2-night event to a close, I would just like to highlight some of the information that we have received from our experts over these past 2 nights and that we have discussed. First, the COVID-19 pandemic has taken a tremendous toll across the world, and many of you may have been affected personally, whether as a healthcare worker or you've had a family member, or perhaps yourself been infected. Vaccines do represent a new and effective tool to fight the pandemic, yet many people have questions and concerns, and we only touched on a few of them tonight, and they need support in their decision-making process on whether to receive the vaccine. For healthcare providers, we encourage you to meet your patients where they are at in addressing their concerns. And it's not appropriate to try to persuade everyone. You know, be consistent and transparent in your communication. Ensure that people feel heard and don't dismiss their concerns. And I think our panelists just emphasized that. There is still a lot we don't know about COVID disease. We don't know about the impacts of these long-term effects that we're hearing about, the long haulers. And there's still information we don't know about the vaccine. We don't know how long we will have protection. We don't know if we will need boosters next year and the next year and so forth. We just don't have these answers yet, but we have learned a lot in the last year and we will continue to learn. As healthcare providers, we need to be honest and acknowledge these uncertainties, and we need to share factual information and not repeat false claims. We need to tailor and adapt our messages to meet our patients' needs. For those of you, whether you're a healthcare worker or not, and you're talking with your family and friends, we need to be sharing the positive experiences regarding vaccination. We need to first recognize that reliance on social media alone for information can be a larger sign of anxiety or isolation that our friends and families are experiencing. And perhaps we have to step in and address that the vaccine hesitancy is a symptom of a larger issue going on with that individual. Reach out and connect with your loved ones. Approach tough conversations from a place of care and compassion. Do not try to change minds, but create a space for conversation where you can share appropriate resources. It's about providing accurate and supportive information that will allow people to make the best decisions for themselves, their families, and their communities, and remain available to them regardless of what their decision is. Importantly, while developing vaccines was step one and promoting vaccine confidence is step two, it's all for naught if we don't get step three right, and that is the actual delivery of vaccines. And I think Dr. Colio, addressed some of these issues. Trust in the vaccine programs will be undermined if the patient experience is poor, whether it be difficulty in signing up for the appointment, whether it be in inequitable distribution or long wait times. Whatever your role or your interest in the US COVID vaccination effort, your engagement in this process is essential. A variety of strategies at the national, state, and local levels is required to change the pattern of our interactions with the public, to address vaccine hesitancy, build trust, and ultimately ensure a successful COVID-19 vaccination campaign. We thank you for your time over these last 2 nights. We wish you all to be safe and to be healthy, and I'm going to turn it back over to Megan.
Hi, thank you so much to once again to the Hahn School of Nursing and Health Sciences for your partnership on this event, and to Dr. Eileen Fry-Bowers, Dr. Pedro Colio, Dr. Dorothy Forde, Dr. Catherine Ferris, and Miss Olivia Kearns for taking the time to participate in this really important 2-part session. As I mentioned before, the Alumni Association and our partners across campus are really working hard on providing content and events and programming that's of the most importance to our alumni. This is a hot topic and we wanted to make sure that we addressed it. Obviously, there are many more questions and many more conversations that can be had. So we encourage you to continue to have those conversations and to ask those questions, and feel free to reach out to us if you have any more that you would like to connect with us about. Thank you as well to all the alumni, students, and parents, friends of USD for logging in to today's event. We hope you found today's webinar to be interesting and informative. And once again, if you have any more questions, feel free to reach out to us via email after the event. To register and to view other programs that the Alumni Association provides, such as our Tiny Toros podcast, which is coming up on its 1-year anniversary, virtual events for affinity and regional clubs, and Hire USD, a campaign where we encourage toreros to hire toreros, please visit alumni.sandiego.edu. Thank you again, and we hope to see you at another USD alumni event soon. Take care, everyone.